Okay, let's start this Abbott sponsor session. This session is Transcatheter H2H mitral valve repair session organized by CVRF and supported by educational grant from Abbott. I am Gru Hong from Severance Hospital, and we have three panelists. It's Dr. Professor Dae Kim and Dr. Mimuk from Thailand and Dr. Morikawa from Japan. I'd like to introduce first presenter is Dr. Ju-Yong Han from Samsung Medical Center in Korea. He will present about a challenging case of the TEER.
Thank you, Chairman. Good morning, everyone. I'm Ju-Yong Han from Samsung Medical Center, Seoul, Korea. My case is mitral clip for DML. Actually, it was not a tough case, but it took much longer time than my expectation due to inadequate puncture height. These are my disclosures. The patient was an 80-year-old woman. She had moderate mitral regurgitation due to prolapsed posterior mitral valve leaflet since 2013. Since 2021, she was repeatedly admitted due to congestive heart failure. She had hypertension and chronic renal disease. These are serial chest X-ray from 2014, 2019, and 2022. The heart size was increased with pulmonary congestion and pleural effusion. ECG showed atrial fibrillation. I'm not an imaging specialist, so I would like to present echocardiographic findings very briefly. The posterior leaflet, very flail. There is a possibility of a coda rupture. In apical two-chamber view, you can see severe eccentric mitral regurgitation due to posterior leaflet prolapse. Systolic pulmonary vein flow reversal was also observed. In TEE, you clearly see the posterior leaflet prolapse with coda rupture, and there is severe eccentric mitral regurgitation. In 3D, you can see also very flail posterior leaflet. Mitral valve area by 3D was 2.85 square centimeter. In the mitral vein, mean pressure gradient in TTE was 2.13 millimeter mercury. From A to P2, A to P23, and A3 P3, there is a marked regurgitation flow. Flail width was 1.74 centimeter, and the flail gap was 0.74 centimeter, and the length of a posterior mitral valve leaflet was 1.28 centimeter. Surgical risk was high. In summary, the patient had a severe eccentric MR due to posterior mitral valve leaflet prolapse with coda rupture. Location was mainly P2 and P3, and the flail width was pretty wide, but with the Giffer system, we can challenge this lesion. Flail gap and length of a posterior leaflet were favorable for mitral clip. Mean pressure gradient was about 2, and right vein systolic pressure was 50 millimeter mercury that were acceptable for mitral clip. Because she needed a recurrent admission due to heart failure, we had to surgery or intervention, but the surgery risk was high. Therefore, we decided to perform TEER. What is important and difficult decision was device selection. My initial idea was implantation of XTW at maximal jet flow, A to P2, in my opinion, and then NTW or other device at A3, P3. But our imaging specialist recommended me to select XT at A3P3, then XTW or XT at A2P2. So I had to follow her opinion. So we started to TEER. Due to time limit, I had to skip some tape to record. So there was a long tunnel of the PFO, but it was not a problem for a septal puncture. After tenting, puncture height was measured. There was a 4.3. There was acceptable. And we measured puncture height at the opposite direction. There is a 4.45, also acceptable. So I punctured this site. But the movement was brisk, and there is a chance of a slippage to the superior and anterior. After septal puncture, wire was inserted, and septal dilation was performed, and the guide catheter was introduced. Caution was needed to avoid damage to the LA wall. Then wire and dilator was removed, and guide catheter was located in the LA. The LA pressure was increased, and you can see marked free wave. Mean LA pressure was 17. CDS was advanced. Caution was also needed to avoid damage to the LA wall. So I introduced the CDS very slowly and retrieved the whole system slightly. The CDS was steadied. After that, I manipulated guide catheter and CDS toward the mitral valve using M knob and posterior rotation. The procedure was smooth so far, but the system was too close toward the aorta, so-called aorta hugging. I had to use plus knob. Plus knob made guide catheter stood, so the distance was increased. After that, I had to rotate the guide catheter anteriorly. And anti-rotation makes the guide catheter to laterally, so I used the M knob. But the aorta hugging was not much decreased, not satisfactory, but I had to continue procedure in this situation. So we had to some hard time to make sure the correct trajectory. Anyway, we could manage it, and after that, we checked perpendicularity in 3D images. And I moved guide catheter slightly medially, and then checked perpendicularity again. So after that, we introduced clip into the LA. Open the arm angle at the 120 degree and try to mount anterior and posterior leaflet. Close 60 degree and clip lock, and we closed the arm fully. The regurgitant flow was much decreased, but the posterior leaflet was redundant and somewhat flail. So we opened the arm and rotated the guide catheter posture slightly, and then tried to grasp posterior leaflet more adequately again. But some residual regurgitant flow was observed, and some in medial portion, some flail movement was observed. So we decided to move the system medially. The arm open and retrieve the whole system slightly and try to grasp both leaflets again. After grasping, the medial portion was very stable, but there was some regurgitant in the center portion. But we had a plan to implant another device at the center portion, so it was not a problem. We decided to deploy the first clip here. After checking 3D, and then we checked mitral valve pressure gradient. That is 1.5. So we deployed the first clip here. And we retrieved the CDS with caution. After that, there was some regurgitant flow at the center portion, but the medial portion looks good. So we decided to second clip at the center portion. Our imaging specialist recommended me to XTW because the mitral valve pressure gradient was only 1.5. LA pressure was decreased and the V-wave was decreased. Second clip was introduced. The same way I manipulated the guide catheter and CDS toward the mitral valve. And I tried to locate the second clip as close to the first clip as possible. But the problem is the height is too low. So to gain height, I rotated the guide catheter posteriorly and used a rope. And slightly retrieved the whole system medially. The puncture height is not so good, so we had a hard time. But anyway, we inserted the guide catheter mitral clip to the LV, and try to grasp leaflets. Due to time limit, I had to skip. So after the second clip, the leaflet and mitral clip was stable, and the regurgitation to flow was very minimal. And mitral valve pressure gradient was 2.1. 3D looked okay. So we had finished the procedure. LA pressure was 11, not much different from compared with the first clip. These are post-T imaging. The leaflet and my two mitral clips looked very stable. And there was a very minimal mitral regurgitation flow. Pulmonary venous flow reverser was disappeared. And the day after the procedure, TT was performed. Flail movement was disappeared, and mitral clip was stable. There was no regurgitation to flow, and mean mitral valve pressure gradient was 4.5, a little bit increased, but it was acceptable. Her symptom was much improved. No further hospitalization was needed. Anti-proBNP was marked decreased after TEER. Chest X-ray was markedly improved. Thank you for your attention.
Thank you for the very educational cases from Dr. Han. Next, we will have a panel discussion after finishing all the three presentations. Next presentation will be Dr. Yoon-Suk Ko. He is in the Hallym University Sacred Heart Hospital in Korea, and he will. His title of the presentation is Beginner's Perspective of TEER. Dr. Ko, please.
Yeah, thank you for your kind introduction, Dr. Hong. I'm Yoon-Suk Ko from Sacred Heart Hospital, Hallym University. It's my honor to be here to presenting my topics. Today's my topic is Beginner's Perspective of TEER. Subtitle is Central DMR versus Non-Central DMR. Before starting, I am the beginner of a beginner. I have no disclosure. In JACC, the published data, the outcomes of TEER between central and non-central MR is published. First of all, the periprocedural adverse event is very rare and similar between the central and non-central DMR. Clip embolization is 0% in two groups, and partial clip detachment is only one in central group and only one in non-central degenerative MR. Prolonged tip entanglement is 0% between two groups. Coda rupture, cardiac tamponade, dry bleeding, stroke, transient AV block, and pneumonia is very rare. And conversion of surgery is only one case in central MR. The death is only one case in non-central MR. Overall complication rate is 14% in central MR and 10% in non-central MR. This graph is the change of the grade of mitral regurgitation according to the time. The baseline, the grade 3-4 MR is about 92%. However, after TEER, the grade 3 or 4 MR is only 4%. At 1 month, the MR grade is similar between two groups. However, at 6 months, statistically there was no difference in mitral MR grade. However, In central MR, the grade 2 MR is increased numerically. However, non-central MR is no increased in grade 2 MR. This graph is showed the NIH class. At baseline, the NIH class 3-4 is about 90%. After TEER, only 15% in NIH class 3 or 4. And once it's similar at after the TEER, after 6 months, in non-central MR, there was no NIH class 3 or 4 patient. However, 20% of in central MR. This is very interesting result. However, hard endpoint, there was no different. This is in two in central, 3 in non-central. Readmission due to heart failure, 4 in central, 2 in non-central. The result is very suitable for non-central MR. We can do the TEER. Before explain the complexity of non-central DMR, let me show the short review of mitral valve anatomy. First, leaflet. The leaflet composed of anterior leaflet is the other named aortic leaflet. The shape is semicircular and broader. However, the circumference annuli is only 1/3. However, posterior leaflet is the another name is mural leaflet. The shape is crescent and narrow. However, the annular circumference is composed 2/3. This is the photograph, the A1, A2, A3, and P1, P2, P3, and anterolateral commissure is 2 components of anterolateral commission and posterior medial commission. The name is according to the papillary muscle. And then the leaflet zone. The zone is composed of 3 zones. The basal zone, the leaflet connect to the arterioventricular junction like this. And clear zone is the central portion of leaflet like this. And rough zone is free edge, the coaptation area. This zone is important because of the attachment of the coda. The coda is composed of 3 components: primary coda, secondary coda, and tertiary coda. Primary coda is attached to the leaflet free edge. This is a very important coda, thinner and higher collagen fiber, limited extensibility, and reduced crimping. The primary coda prevents leaflet edge eversion and flail leaflet. Secondary coda attached to rough zone and thicker and more extensible. Tertiary coda attached to basal zone of the mural leaflet, posterior leaflet. This picture is showed the difference of the central and non-central MR. There is a coda-free zone in central part of anterior leaflet is A2. There was no coda area. However, the structure of coda in commissural area is very more complex like this. So the non-central MR is the more challengeable of the TEER. The normal morphology and central MR, the 3DT image, this is normal mitral valve morphology, the anterior leaflet and posterior leaflet, anterolateral commissure and posterolateral commissure like this. However, central MR, the P2 prolapse is like this picture. This is prolapse of P2. However, the commissural MR is extreme non-central MR. This picture is isolated posterior medial commissural prolapse like this in 3D T echo, and this is surgical findings. This is PMC prolapse, isolated PMC prolapse. The treatment was surgery by 4 neocoda and posterior band annuloplasty. This is flail posterior medial commissure. The white arrow is the ruptured of coda, like this. 2 coda is ruptured, like this. And another viewpoint, another direction, the PMC is prolapsed and ruptured coda in 2D TT image, the rupture code can be detected. This is very extreme non-central MR case, combined prolapse of anterolateral commissure and P2 scallop like this. Anterolateral commissure is prolapsed and P2 is prolapsed. This is very extreme case of non-central MR. So the non-central MR is very complex anatomy and complex mechanism of MR. The surgical treatment is various technique and the combined need combined technique. Ring and band annuloplasty with the first method, resection or application of prolapsing or redundant leaflet tissue. Second method, papillary muscle repositioning and coda transposition. Third method, coda replacement with extended PTFE nerve cord. Finally, the simple commissural closure. This is a simple closure, very simple surgical technique. It's standing the test of time. Is very good long-term outcome. So this concept of commissural closure is similar to mitral clip. So we can treat the non-central MR by mitral clip. However, not expert for the beginner of TEER, I introduced two cases. This first case is a very good result of central MR. The patient is 82-year-old male. ST score is high. ECG is AF. The main central MR A23 prolapse. This is 3D T, A2 and A3 prolapse. It's very large. The central DMR. This is explained. The standard explain is we can detect the MR is very good. This is bicommissural view and long axis view. The central MR is severe. And we start the TEER in first clip. The first clip is the A3 and P3 portion. After one clip, there is the remnant severe MR, and the motion of the clip is very unstable. So we decide to the additional clip. This first clip is XTW. Second clip is NTW. We decide to put the NTW. Second clip is the attached the mitral valve. There was minimal mitral regurgitation. This is 3D image. There was minimal mitral regurgitation because we detached the clip from the CDS. After the detached CDS, the mitral regurgitation is very minimal, and the motion of mitral clip is stable. This is happy result. However, the second case, let's introduce. He is 57-year-old male, very young patient. ST score is intermediate surgical risk. However, he have severe liver cirrhosis, child C with HCC and LT candidate. So the stressful for open heart surgery, we decide the mitral clip. The EKG is paroxysmal AF. The finding of echocardiogram extremely commissural MR, P3 and PMC flail. Flail gap is 4.5 millimeter and width is 18 millimeters. The standard explain we cannot detect the MR exactly. The tilting from the standard explain we detected the MR is exactly. This is 3D image. There was P3 prolapse and PMC prolapse. Maybe minor coda is ruptured. This is first clip. First clip, we put the medial part. However, we wish to the extremely medial to the PMC. However, we can locate it at the part. So the minimally laterally from the PMC The first clip is the first clip is XCW, and clip first clip, and the remnant severe mitral regurgitation was observed. So however, the fluoroscope, the clip motion is not unstable. However, the severe remnant MR, we decided to the one more clip, NTW. The second clip is introduced, put into the LV, and grasp the mitral anterior and posterior leaflet, slightly lateral to the first sleeve. The second clip showed the slightly decreased MR. We detached the clip from the CDS. After detaching the CDS, there was more severe MR was observed. The severe MR due to the coda rupture, like this point. So at that time, the pressure gradient is only 4 millimeter mercury. However, there was no space of the another clip. We cannot perform the additional clip. We decided to the surgical conversion. This is OP findings. There is a single leaflet detachment of posterior leaflet. This is anterior mitral leaflet. Is hardly the bite of the mitral clip. However, there was no tissue and any other tissue between the grasper and clip arm of the PML. In OP finding, PML is very second and frail, and there was many coda ruptures. The surgical treatment is by replacement by tissue valve. It's very painful experience for me. This is my conclusion. The commissural MR is challengeable for TEER so far. However, the concept of TEER is suitable for commissural MR like surgical commissural closure, as I mentioned. So the pre-procedural planning, such as location and number of clip etc., is very important. In case of central MR, the perpendicularity is 12 and 6 o'clock. However, ALC is 1 and 7 o'clock. PMC is about 11 and 5 o'clock. In a few latest published cases, commissural MR used by 2 clips and vascular block on the gap between the 2 clips is treated successfully. Is the new concept of the treatment of commissural MR. However, especially in beginner, should be very careful and cautious in commissural MR. And if you are beginner, must consider again open surgery in extreme commissural MR. Thank you for attention.
Thank you, Dr. Go. It's a really educational messages from the beginner. And next presentation will be Dr. Do-Yoon Kang from Asan Medical Center. He will talk about recent clinical data update of mitral clip.
Yeah, thank you for your kind introduction. I'm Dr. Kang from Asan Medical Center. Today I will talk about the recent clinical update, the data update of the mitral clip. Because there are so many updates, I cannot review everything in 15 minutes, so I selected some topics of the newer clinical data and some data about the G4 clip and about the procedural outcomes and atrial MR clipping. Now, after first in-man use about 20 years ago, FDA approved the clip for the DMR after the Everest 2 trial in 2013 and approved for the functional MR 2019 with the co-apt result. And the first case was done in Korea 2 years ago, and now we are using the G4 device. And the recent guideline from US is recommending the TEER, Transcatheter edge-to-edge repair that calls the mitral clip, For the primary MR as a 2A/B recommendation for severely symptomatic MR patient with a high or prohibitive surgical risk with a favorable anatomy. And for the secondary MR patient as a 2A/B recommendation for chronic severe symptomatic MR patient even after optimal guideline-directed medical therapy with a COAP-like subset patient with the LV ejection fraction 20 to 50%, with the LV end systolic diameter equal or less than 70 millimeter, and pulmonary systolic pressure equal or less than 70 millimeter mercury, and with the appropriate anatomy for mitral clipping. And with these new guidelines, and updated outcome data was shown. First of all, in last year JACC, the MicroMag, a surgeon, showed the STS and ACC TVT registry report with the real-world outcome of the mitral clip. It showed that in-hospital death was 2.2% with a 30-day mortality with a 4.5%. And the mitral valve reintervention rate was like 1%, and the rate of the moderate to severe or severe 3+ or 4+ MR after procedure was 8.7%. And 1/4 of the patient had the increased mitral valve gradient more than 5 millimeter mercury after mitral clip. And the more important thing that was shown in recent report is that there was some durable result in longer term follow-up. In 5-year outcomes of the Everest 2 trial and REALISM 5-year outcome, the 87% of the patient was shown to keep the mitral regurgitation grade equal or less than 2. And even with the COAP 3-year outcome, it was maybe about the internal data, and about 99% of the patient showed the mild degree or less than mild degree of the MR in 3-year follow-up. And also the important thing is that when compared to Everest REALISM, the first generation device with the expand primary MR subject with a third generation device, and the degree of the MR reduction was much better with the better device and better experience. And with this experience and improvement of the device, and the grade of the successful implant rate is increasing over years. In Expand G4 registry, about 90% has the mild or less than mild MR after clipping. And the most important recent update would be the newer G4 mitral clip introduction. It has the various length and width of the clips with the 4 sides, the narrower NT or XT, and wider NTW and XTW, and shorter NT series and longer XT series. So we can select the clips by the anatomy and the patient indication. And usually, with the smaller mitral valve area, recommend the smaller the clip is recommended, and with the wider jet and the wider clip is recommended. And in real-world registry with the G4 clip in Expand G4 with more than 500 patients, the mostly used clip was the XCW and NTW. And the more about 60% has the one clip with the XTW or NTW, and some minor patients use the mixture of the clips. And with the newer G4 clip, the degree of the MR reduction equal or less than 1 plus was about 90% and better result compared to the previous Expand registry. And the real-world safety and durability of the G4 mitral clip was shown in this year's TVT presentation. They showed the 30-day event rate of the all-cause death as the 1.5% and 0% MI or stroke, and less than 1% of the CV surgery or just 1% of the leaflet adverse event like single leaflet device attachment. And so the data shows that the newer clip shows better clinical efficacy and safety with a durable result. And another issue is how to obtain the optimal procedural outcomes. Usually the TEER success was defined as the MR reduction equal or less than 2 plus MR. However, successful MR reduction or success may vary among patients. Very severe MR patient, we cannot make the regurgitation grade to trivial or mild in some patient, and the reduction would be a success. And another issue is the absence of the significant mitral stenosis. Usually mean gradient equal of less than 5 mmHg is defined as the absence of the MS. But in some trials, increased gradient was okay, especially in secondary MR. Let's review the data. Because TEER reduces mitral valve area, therefore it increases mitral valve gradient. It's like a double-edged sword of the mitral clip. And the predictor of increased mitral valve gradient is the mitral valve orifice area, smaller area, usually less than 4.0, and baseline increased mitral valve gradient, usually less or more than 4, and mitral annular calcification, hemodialysis patient, and more clips used, and higher residual MR with the increased blood flow makes higher pressure gradient. And recently, contrasting result of the impact of the high transmitral gradient after TEER for primary MR was published. Previous data from Jaha in 2019 showed that the increased pressure gradient after DMR mitral clip was shown worse clinical outcome. And recent issue in JAG intervention showed 2 articles with the contrasting result. One result from the German single center, mortality and heart failure hospitalization was a little bit worse in patient with the increased pressure gradient. And from the Cedars-Sinai result with the 419 patient, the mortality was not different by the pressure gradient after DMR mitral clip. So we need more investigation with this patient. And the most important thing is that the residual mitral regurgitation grade was stronger predictor even than mitral valve gradient, even in the DMR patient. In our data, as I first showed, the pressure gradient was a predictor of the outcome, but the residual MR gradient was more stronger event predictor after mitral clip. And for the secondary MR, there is only data from the COAB trial subgroup analysis, and mean pressure gradient after mitral clip was 4.2 in COAB trial, and when classified as the quartile, the Q4 with the 7.2 mmHg mitral valve gradient also showed similar outcome with the lower pressure gradient. And as shown in this graph, the mitral valve gradient was not predictive in the future death or heart failure hospitalization. And also in COAB trial patient, MR reduction was stronger predictor of clinical outcome, much more than pressure gradient. So when adding all the evidences until now, I think that the minimizing MR grade would be more important than decreasing mitral valve gradient. Also, the recent article in Circulation Intervention showed from the German single center showed when the patient developed recurrent MR within 12 months, it showed worse clinical outcome than the non-recurrent MR. And the most stronger predictor of the recurrent MR was the MR2 plus at the end of the procedure and flat leaflet. So when we perform the mitral clip, reducing the residual MR grade would be the most important. Final issue is the TEER in atrial functional MR. The atrial functional MR means the isolated annular dilation developing with the atrial fibrillation. There was the atrial fibrillation, and with the LA becomes bigger and bigger, and with the inadequate leaflet adaptation, there begins the mitral regurgitation by the atrial fibrillation. And there is some limited data about the atrial FMR mitral clipping. In global expand registry, and was presented last year in TCT. When do the atrial FMR clipping, MR reduction was acceptable range, especially in the atrial secondary MR, and NIHA class was became better after clipping. And in this registry, the number of the patient was 53, very small registry. However, the degree of the heart failure hospitalization at 1 year was less than 12%, and mortality was 14% after 1 year, showed acceptable outcome. And recently in the EuroPCR and co-published in International Journal of Cardiology, the TEER in atrial FMR in Europe was published. The mitral tune registry with 87 patients with the LV ejection fraction more than 50% and smaller LV and diastolic diameter and atrial fibrillation with the 81-year-old patient was enrolled. And after mitral clipping, the MR grade was less than 3 in 90%, and the patient symptom improved, and LA diameter and the LA volume was decreased after clipping. And also, the 83% device success rate was shown, and in-hospital death was 2%, and 30-day mortality was 5%. And all-cause death or heart failure hospitalization at 2 years was 55%. And with this result, there is some data from the real-world registry for atrial functional MR patient, and still we need more data, and we are doing such a case and should gather the data in Korea or Asian data, I think. And there are some ongoing clinical trials. I will just show the important clinical trials. One is the mitral HR trial that comparing mitral clip versus surgery for a high surgical risk primary MR patient. Because now the mitral clip is approved for degenerative MR by the EVEREST-2 results subgroup analysis with a high risk subset, the trialist, the investigators are doing the randomization of the mitral clip for surgery in patients with a high surgical risk, age more than 75 years old, and STS score for repair more than 6%, or age less than 75-year-old and STS score for repair more than 8%. And they will investigate the primary endpoint of the all-cause mortality and unplanned hospitalization for heart failure and mitral valve intervention at 12 months. The trial will be assessed by the non-inferiority. Now, another big trial is the repair MR trial, mitral clip versus surgery for moderate surgical risk in primary MR patient. And the patient with the patient with a 75-year-old or more or older or younger than 75-year-old and SS score more than 2% and moderate surgical risk. The primary endpoint will be death, stroke, cardiac hospitalization, acute kidney injury requiring renal replacement therapy at 2 years. And they will randomize 500 patients by one. And I will summarize this clinical update of the mitral clip. The real-world registries showed higher efficacy, safety, and durability with contemporary mitral clip G4 devices. And obtaining optimal MR reduction was the key for better long-term clinical outcome. Reduction of MR seems more important than reducing transmitral gradient, especially in secondary MR patient. And mitral clip is trying to widen its indication to moderate risk primary MR or atrial functional MR. Thank you for your attention.
Thank you, Dr. Gang. I'd like to open this whole presentation to panel discussion. There are 3 panels from the world. Dr. Dae Kim is an imaging specialist, and Dr. Mimuk from Thailand, and Dr. Morikawa is online. So please go ahead.
I would like to comment the case from Samsung Medical Center. The product segment seems to be diffuse P2 prolapse rather than P3 extension, but I think the flail gap was 17 or 18 millimeters, right? So using use of two wide clip is reasonable, I think. But you can make two clip to be a little bit closer than your case. You can reduce pressure gradient up to 3 millimeter mercury. That's my comment. Yeah.
Hi everyone.
What about the
sorry.
ordering of mitral clip? Do you
Yeah,
recommend
but the
it?
two wide clip is reasonable. But
I mean order. The center first or medial first?
central post, but not. I think the diffuse P2 products with the phrase segment, not P3 extension, in my opinion. But I look at two clip just medial from the central, just lateral from the lateral and medial, and the two clip separated by in the central region. I think.
But what about the length? I think this patient is very old and relatively not very big size of the left atrium, and septal height is not very high. So in our cases, usually we recommend NTW first because flare gap is not very big. It's about 7 millimeter, and flare width is very wide. So wide type is I agree with that, but I don't want to recommend XT rather than I'd like to recommend NTW first.
Yeah, but if in our center we would try first the XTW clip. Yeah, I agree with Dr. Han's comment. Yeah, try yes.
Dr. Morikawa, do you have any comment?
Yeah, and so regarding to the mitral valve anatomy, so I'm talking about case one. Regarding to the anatomy, I'm totally agree with Dr. Kim. So the MR segment is a large piece of flare. So I'm go for the two clip, and I'm go the medial first, and then go to next to the next to the first clip. And I'm talking about so I want to mention about the technical perspective. So especially for the second clip, in the second clip case, with full oral, you need to pay attention to the full oral. After the grasping, the second clip should be more LA side. You know what I mean? So this means you can take you need to take much more tissues by the second clip. So it means the second clip should be go much more LA side in the with full oral. So you need to pay attention to the full oral in the second clip case. This is my comment.
Okay, Dr. Mimuk.
Yeah, I do agree. Dr. Milk from Thailand. I do agree with every panelist. I think for the first one, Dr. Han case, in my routine, I always use XTW as the first one because the valve area is okay and leaflet length is okay because if we got much more tissue is reduction and liberalization is better than the smaller one, and after that we can decide which one we should use, NTW or XT. That's my comment, and I may do a little bit different because the major pathology is at the medial part. I may do the at the A2P2 first at the fail segment, and after that I will do the second medially. And for the second lecture, the second case, the commercial case, I may do a little bit different. I try to do the very close to commercial first with the like a NT, a small and short one to the medial first, because if we put the XTW away from the commercial and we try to put the second one in very medial commercial, sometimes the imaging quality is not so good to evaluate the leaflet insertion, because if the very high risk like this, I try to optimize the first one medially first, and after that we put the second one laterally. That's my
Okay, how about Dr. Kim for second case?
Yeah, the commercial Dr. Go's commercial I'd like comment, but the main problem of commissural MR case was the first clip placement. In commissural MR case, first clip placed in the PISA, but as you can see in your slide, the mitral jet three components: PISA, neck, and distal jet. Your first clip placed in the distal jet, but you must place first clip in the PISA just before the neck. After then, your second clip, in our center, we usually use NTW XT in first clip in commissural MR. After then, you can use wide clip covering neck and side, some part of distal jet. Yeah, that's our tip.
Yes. How about Dr. Morikawa about second case?
Yeah. I'm gonna go for the first clip as medial as much as possible to the medial because you left the residual jet in the medial side. It's difficult to do it, right? So there is no space to place another clip. So first clip should be more medial.
Yes, and make sure you do better put the clip is not too deeply, just in the commissural MR, and just open the clip in just beneath the leaflet. That is very important, and you do better use the shorter one, and then the wider one, and that is better for the commissural MR. And what about in the presentation from Dr. Kang? Do you have any comments? And actually, what about in terms of atrial MR? It's very difficult for us, especially in the imaging specialist. Yeah. So most of atrial MR, they have mostly they have a combined severe TR. So in the young age, about in their 60s and 70s, if we want to recommend mitral clip or some intervention, the surgeon, they don't agree about that because they have combined severe TR and MR. Do we have any data about simultaneous TR in the atrial MR in the clinical data?
Actually, I could not find such a kind of data. There was only case reports and some experiences, but there's no big size data. So, and I also agree with your opinion that when we need to correct the TR, surgery would be the best treatment option. And also the TriClip or other tricuspid treating devices is not yet available in Korea. So I really recommend surgery for such kind of patient. And if the TriClip or other devices are available, I am very curious that the treatment option will be different from now. In Thailand, is the TriClip available?
Yes,
how about
we got access to the TriClip now, but my routine practice, if we got the patient with the combined atrial functional MR and TR, we try to treat the left side first, and we wait for 3 or 6 months and reevaluate the TR. If the patient still have the severe TR, we bring the patient back to do the TriClip. First 6 TriClip case of us is just we don't do the concomitantly. We just waiting for the first procedure, not doing together.
What about in Japan?
Actually, now we can use only the trial case, but I have some experience in CDAS with the TriClip case. So in CDAS, we try. So we fix the mitral valve first, and then give the time to the patient, like 1 or 2 months observation. After that, after mitral clip procedure, if the patient still remains symptomatic, the patient go for TriClip. That's good.
Yes. Is there any comments or question from the audience? So, okay, time's up, and thank you for all the presenters and the panels. It's a really great session for the educational purposes in the TEER. Thank you very much.
Thank you.